Hi, welcome back to our last segment of our first day of SCCAPE. We are going to continue our discussion about health disparity and race and stigma bias in this country. And our next guest I'm privileged to introduce is Dr. Michael Royster, who is currently the Senior Vice President of the Institute for Public Health Innovation. He has established the Institute's Richmond office and is expanding and developing initiatives to support public health priorities across Virginia. He provides expertise and oversight for the extensive portfolio of programs, including community health workforce development, health and all policies, training, and technical assistance on creating healthy and equitable communities, community health improvement planning, and immunizations. Dr. Royster, we're very grateful to have you here today. Thank you, and I'm going to turn this over to you.
Thank you, Shirley, and thanks, everyone. I'm excited to be here to talk with you today about racism as a public health crisis. This presentation really builds on work that I, along with my colleagues at IPHI and partners, developed over the last year, where we created a webinar series entitled Racism is a Public Health Crisis in Virginia, to draw attention to that fact and to publicize, really, based on a resolution that a member of the General Assembly, Della LaCherice Aird, introduced and was approved by the General Assembly in 2001. This legislation, which was known as House Joint Resolution 537, was introduced and approved on February 21st, 2001. It was the first, resulted in Virginia being the first state in the South, in particular, to declare racism as a public health crisis, and really, I think, propelled Virginia into the forefront with many other states that have started to do this work. As a part of the resolution, Virginia focused on advancing the role of the Office of Health Equity to address racism, kind of as the lead organization in Virginia to do so at the state level, as well as to make permanent a commission to examine racial inequity in Virginia law. And this commission looked at laws on the books in Virginia to identify those that were either outdated, that reinforced structural racism, or those that, even not explicitly racist, could make racial impacts even worse. And so the goal was to expand and make this commission permanent. The resolution also focused on training on implicit bias for state employees, establishing a glossary of terms on health equity, and then also really focusing on authentically engaging communities to address racism and other issues of oppression. And I think this is really a critical factor that comes out in healthcare, as well as in public policy and in public health. And so in addition to Virginia, there are efforts across the country to make declarations at the local and state level, including in Richmond City, the former capital of the Confederacy, and the only locality to date in Virginia to make such a declaration. In addition, school systems, local and state health departments, and governors and mayors as well have made similar proclamations throughout the country. And in total, there have been over 209 declarations in 37 states passed. And so with the interest in making such declarations increasing, as well as the really backlash that we're seeing in response to the racial reckoning that our country has gone through, is really critical to discuss this issue and explore it even more. And so in order to do so, we really have to start by asking, what is a public health crisis? And Dr. Sandro Galeo, Dean of the Boston University School of Public Health, defines a public health crisis using 3 criteria. The first is that the problem must affect large numbers of people, it must threaten health over the long term, and it must require the adoption of large-scale solutions. And so with these criteria in mind, let's see how well racism fits that definition. And of course, in order to do that, we also have to define what racism is. And so for that, we turn to Dr. Kamara Jones, who's a physician epidemiologist who's spent her professional career studying the impact of racism on health. And as you can see on the slide, she defines racism as a system consisting of structures, policies, practices, and norms that shape opportunity and assign value based on how people look. It unfairly advantages some individuals and communities and unfairly disadvantages others. And ultimately, racism undermines the full potential of our society. And so this definition, I really want to, take everyone to really pay attention to, because it's beyond what we usually think about. And on the next slide, we'll go into even more detail around what racism is. And so let's explore, again, as Dr. Jones described it, that system and its structural components. So structural racism can be thought of as occurring across 4 levels that are interconnected and mutually reinforcing: the personal, interpersonal, institutional, and cultural. And so without understanding all of these levels, I think in our society we have a tendency to get stuck talking about the first or second level, the personal and the interpersonal, and then we miss the forest for the trees. It's also important to note that racism intersects with other forms of oppression, whether it's classism, sexism, homophobia, etc., to create intersecting experiences of oppression in our society. So let's go on and look at these 4 levels in more detail to get a better understanding of how racism operates in the United States. And so as I mentioned, the personal level, which relates to the values, beliefs, and feelings of an individual regarding the superiority or inferiority of their own or other racial group. I'll point out that, as we looked at Dr. Jones's definition, when we're thinking about the United States, the system of racism is really based on the belief in the superiority of whiteness and white people compared to communities of color. And so when we talk about that personal level, it's really regarding the superiority or inferiority of your race relative to whites, or whites relative to other races. And so going from the personal to the interpersonal, this really connects the beliefs and attitudes that people have to the actions that they take. Typically we see this in very extreme cases. So in recent years, we've seen white racist attacks and murders of Ahmaud Arbery in Georgia, and the recent murder and physical and verbal assaults of Asian Americans that have increased in the last year or two as well. And of course, we can't forget the police-associated murder of George Floyd and Breonna Taylor that really reinforce the extreme of those interpersonal experiences. But even outside of these extreme and horrific events, we also see daily examples of both explicit and implicit bias that leads some healthcare providers, for example, to prescribe pain medicine to Black and Latino patients in the emergency room at lower rates than white patients who present with the same complaints of pain or similar complaints. Similarly, we know from data that implicit bias also results in healthcare providers in the ER being more likely to refer parents of children who come in with injuries to protective services for evaluation than white parents whose kids have similar injuries. And so this example of interpersonal level is more subtle, but still is relevant in our communities and particularly in the healthcare community. If we move to the next level of this system of racism, that is the institutional level. And this really refers to the laws, policies, and practices within and across organizations, institutions, associations in our communities, et cetera, and whether they're intentional or not, but that produce outcomes that favor whites and put people of color at disadvantage. Institutions within our society consistently produce racially inequitable outcomes. For example, through school funding policies, disciplinary practices within schools, public health and healthcare services, as well as research, housing segregation and discrimination, disproportionate police killing of people of color and mass incarceration of people of color, employment discrimination, banking and finance through subprime loans, and other examples of underinvestment in communities of color. We could also look at the food system and access to healthy foods and affordable foods that are differential by race and ethnicity. Even current voter suppression legislation in many states that, while not explicitly, clearly underlying is the attempt to reduce the voting power of people of color. We could continue across every sector, every system, every aspect of our society and find racially inequitable outcomes. And that would document that racism does exist not only at the interpersonal and personal level, but also the institutional level within our society. The glue that holds it all together is the cultural level of racism, which reinforces that notion of superiority of whiteness, which we also refer to as white supremacy culture, and reinforces it at the individual, organizational, and institutional level by establishing and reinforcing society's shared values. So the things that we find valuable and lift up in our society are disproportionately based on white cultural norms and the expectation that whiteness is the standard by which others should be judged. Fortunately, we've begun to address this. If we think in Richmond City, where I am, until the last few years, there were statues commemorating Civil War generals in one of the major streets in Richmond City, which really is an example of cultural racism. It's identifying who are the heroes that people celebrated, and they were people from the Confederacy. Fortunately, we started to recognize that, but again, this cultural level permeates all aspects of our society, and so we have to think about that and how that reinforces the other levels of personal, interpersonal, and institutional. And so ultimately, the system of racism not only shapes but also reinforces the distribution of the social determinants of health over time and across generation. And so this slide reminds us of some key points about social determinants of health. Their distribution is responsible for most health inequities. They influence health through their impact on individual access to health care, the ability of people to engage in healthy behaviors. So for example, if you live in a community that is a food desert, the ability to eat healthy food is significantly limited. As well as exposure to environmental threats such as lead in drinking water or violence in communities. And then another piece that I think is really critical in terms of how social determinants affect health is their effect on the physiologic and psychological components of stress that can predispose people to poor health outcomes, both physical and mental health outcomes. And so toxic stress is associated with navigating adverse social determinants of health. The anticipation of and experiences of interpersonal racism and social exclusion at the cultural level is a common pathway. Racism impacts health by causing overactivation of the body's fight or flight response with the release of adrenaline and stress hormones, including cortisol, which can increase the risk of a variety of adverse physical and mental health outcomes. There's also evidence that the ongoing stress of racial trauma causes epigenetic changes in which genes can be turned on or off in such a way as to increase the risk for chronic diseases. And then these altered genes can be transmitted from generation to generation. And so not only do we tend to think about social determinants affecting health through people's access to healthy food or physical activity. And so this really reminds us that the stress of the challenges of navigating limited healthy social determinants or the actual experiences of racism can affect the body through stress and through the multiple organ systems that are then affected as well, resulting in increased risk for a number of adverse health outcomes. And so if we then look at some of the data that documents, again, the inequitable access and distribution of these social determinants, we can look here and see the elevated prevalence of child poverty by race and ethnicity, with Blacks and Hispanics showing the most elevated rates of childhood poverty. And again, the history of residential racial segregation, job discrimination, educational and health inequities lead to higher rates of poverty among children, families, and communities of color, as well as the associated physical and mental health implications of growing up in poverty. Not surprisingly, many children that grow up in poverty also live in families that experience housing instability. In Virginia, families with children who have little or no confidence in their ability to pay their next, this is United States data, little or no confidence in their ability to pay their next rent or mortgage payment, again, are disproportionately Hispanic and African American across the country. And again, the stress and other health-related barriers associated with housing instability and substandard housing are disproportionately experienced by families and children of color. As I referenced food insecurity previously, and again here we see data on food insecurity demonstrates the inequities by race, with Black and Hispanic residents in the United States being much more likely to experience food insecurity, which we know is related to many adverse health outcomes, as well as the stress of having limited access to food. So given the inequities in these and many other social determinants, it's not surprising that we see corresponding health inequities across the country. Low birth weight, which is an indicator not only of inclusive, high-quality prenatal care, but also maternal health and the overall well-being of a community, is roughly twice as high for Black babies compared to white babies, and is also elevated for Asian Americans slightly, and for American Indian infants, or infants born to American Indians. And so we also see, if we were to look at maternal mortality, we would see similar inequities. And so if we think about what we've talked about so far, so with our understanding of structural racism and how it influences the distribution of social determinants, toxic stress, intergenerational trauma, and life opportunities among Black women, it's not hard to see why we would see a significantly elevated rate of low birth weight. And we know that low birth weight born babies then have greater likelihood of infant mortality, of developmental delays, other challenges as they grow that continue that challenge across generations that we see in the Black community. And then so finally we turn to COVID-19, which of course is the current and most glaring example of the impact of racism on health that we are able to see in real time. The data here shows the age-adjusted rates of both infection, hospitalization, and death for communities of color compared to white people in the United States, and the white population is at a risk of 1.0, and then other populations, their risk is relative to the white population. And so here you can clearly see again the elevated rates or risk of infection, hospitalization, and death among communities of color in the United States compared to white populations. And these inequities are directly related to the historic and present day effects of structural racism and its impact on social determinants. And so if we think about explicit and implicit racial discrimination in employment, education, and housing, which then leads to people of color being overrepresented in many jobs that were considered essential during the pandemic, such as food processing, grocery store clerks, delivery service, bus drivers, healthcare support, et cetera, then these are the folks who are at greatest risk and who have been at greatest risk of being out in communities and being exposed to COVID in the first place to get sick. If we also think about how the pandemic, of how the historic and ongoing inequities in access to social determinants, the chronic intergenerational stress that has led to higher rates of chronic disease among communities of color. Then if we compound the higher risk of infection with also being more likely to have heart disease, diabetes, cancer, et cetera, which puts people at risk for complications from COVID, then we can also see how, for example, the higher rates of hospitalizations and deaths occur. And then if we look at also the historic both distrust and the actual racism that has existed in the healthcare system and lack of access to health insurance, then those people of color who are at greater risk for exposure and of having adverse outcomes then have less access to health care to treat the complications that they've had. And so when we think about these intersecting aspects of racism, we can see how the pandemic of COVID-19 has really exemplified how racism is a public health crisis. And so in addition to the impact on health and quality of life, loss of life, there are significant monetary costs that society faces because of racial health inequities. These can be thought of as opportunity costs, which could be redirected to creating a thriving and inclusive society that allows everyone to achieve their full health potential. If we address the existing inequities and their root causes, then we can, potentially achieve this potential. So let's return to the 3 criteria proposed by Dr. Galea to define a public health crisis. First, the problem must affect large numbers of people. We clearly see the health and social implications of racism across communities of color, which account for 30% or over 30% of the population in the United States. If we consider how racism is used as a wedge to prevent people of color and poor and working class whites from addressing the socioeconomic inequities they experience collectively, then the impact of structural racism is much greater. The problem secondly, the problem must threaten health over the long term. Racial health inequities have been persistent across generations, and in addition, new health threats such as COVID, as we've seen, continue to disproportionately affect people of color. And third, the problem must require the adoption of large-scale solutions. Because structural racism is rooted in our collective history and continues through current interpersonal, institutional, and cultural factors, it will require broad, large-scale solutions across all aspects of society to achieve racial and health equity. And so I conclude with a slide to just reinforce that it's clear that racism meets the criteria to be designated a public health crisis. In fact, Dr. Rochelle Walensky, director of the CDC, recently acknowledged this fact, as has a growing number of public health leaders, local and state governments across the country. And so with that, I will stop here and entertain questions with Dr. Smith.